welcome everybody. So you can see from your messages, we've got UK, Belgium, South Africa, India, Manila. So welcome to this wide audience. We're going to talk about something quite new. I'm going to introduce Ludger Hanneken, who's going to introduce the concept and how this all came about. So we're talking about the Novoxel Tixel treatment, which is a fractional thermo mechanical treatment for dry eye symptoms. So Ludger's a German ophthalmologist who now lives in Andorra, Mallorca, and Barcelona, depending on which day of the week it is. And he's going to tell us his initial experience with this. Thank you, Ludger.
Sunil, thank you very much. Right now, I'm only living in Andorra because we can't pass the borders. That makes things a little bit different, but that's how it is. So thank you very much, everybody. Good morning, good afternoon, depending where you are in the world, for your interest. How did I start with Tixel therapy as an ophthalmologist? Is for the non-ophthalmologist in the audience. You see here on the right side the structures which are involved in the tear production, and you have the lacrimal gland in the temporal side of the upper lid, which is responsible for the aqueous part of the tear film. The Meibomian glands, which are in the upper and the lower lid, responsible for the lipid layer of the tear film, and then the goblet cells, which are important for the mucin layer of the tear film. And maybe I just tell you a little bit in a chronological way how all this started. So I'm doing ophthalmology, of course, in my clinic, but as well we have an aesthetic department where we offer various treatments, and one of these treatments was and is, of course, the Tixel treatment in the PeriOrbital and in the facial area. I will show you later two pictures how this looks like. During this treatment, we observed this very positive effect on the dry eye disease, which was a big surprise for us, of course. And then we looked at this a little bit more, and we developed, depending on the early experiences we have made, treatment protocol, and treated many patients, made a retrospective study just as a proof of principle. And after we've done that, we decided, together with the manufacturer, that we will plan and start a prospective clinical study together with Professor Shah, and in Andorra, in UK, and in Cambodia, which is in progress right now. And meanwhile, after I've started that, I have personal experience with hundreds of patients which I've treated, very good experience, and patients are happy and come from far away from France and from Spain to get their second and third treatment, because they realize very positive effects, and we don't have any significant side effects. Just to show you in this video how a non-invasive blepharoplasty looks like, and a wrinkle treatment. And if I show you later on the video of the dry eye treatment, you can see that it's nearly the same. I mean, we go a little bit higher with the blepharoplasty treatment than with the dry eye treatment, but it's basically a very, very similar treatment, maybe with slightly different parameters for the Tixel device, but technically it's the same. And here you can see examples how the effect looks like, the aesthetic effect after a Tixel treatment, before and after. Here is a second image. And this is important, because if you explain and propose to your patients that you want to treat their dry eye, problems with the Tixel device and explain them. You have to be careful because the secondary side effect of the treatment is that you will improve your wrinkles in the periorbital region. Many patients, even if they don't think about their dry eye treatment, they agree right away because, as you can imagine, most of us would accept such an secondary effect of a treatment. Talking about dry eye disease, some background information. It has become a hot topic lately, and there are more and more groups which are doing a lot of research in relation to the dry eye disease. Right now, an international important group is the TIFUS group, and they defined with the DUS2 the dry eye disease in a way that it's a little bit more structured. In this group, the dry eye disease is characterized as a multifactorial disease, and the central parameter is the loss of homeostasis of the tear film, and this accompanied by the ocular symptoms, which we all know, the instability of the tear film, hyperosmolarity, inflammation, surface inflammation, etc., etc. Dry eye disease is like a global epidemic, and we have between 350, 400 million patients worldwide suffering from dry eye disease, with a prevalence between 5 and 34% in older patients, and pre-cataract patients, post-cataract patients, up to 70%, so very, very high. In Asian countries, you have nearly 50% of patients suffering from dry eye disease, and there are various reasons for that. Clinically, we can differentiate between the decreased tear secretion as the reason, the cause for dry eye disease, aqueous deficient, which is responsible for about 20% of the cases, and the increased tear evaporation, which is responsible for about 80% of the cases. And between these two cases, there exists a lot of mixed type. In contrast to this definition, which we just heard, the Asian group, ADIS, they define dry eye disease mainly caused by tear instability, and they don't see inflammation as the root cause. It's more a result. And because of that, they developed a new concept for the diagnosis, which is the tear film oriented diagnosis, and consequently the treatment, which is then tear film oriented treatment, they call it. They use a lot of artificial tears, punctal clubs, but as well other pharmaceuticals which are not available in most countries in the world, which is diclofosol and repamide. They do, because they do have this different concept in dry eye disease, not the possibility to use in Japan, for example, cyclosporine, so Restasis or Levetiracetam, Xidra, which in the US they use a lot because their concept is more the inflammation concept. And because of these different concepts, there are different treatment algorithms proposed. This is the algorithm of the DUS2 group. But basically, overall, the treatment and the management of dry eye disease it remains something of an art. And there is a need for innovative treatments because many patients are not happy with what they receive. They have frequently a frustrated journey from one clinic to the other clinic, from over-the-counter drops which they use. And I think we do have the responsibility, but now we have the possibility to treat them in a different way. very frequently associated and very frequently the reason and the cause for the dry eye disease is Meibomian gland dysfunction. I showed you in the first slide, these Meibomian glands, they're responsible for the production of the lipid layer, and they're in the upper and the lower lid. And you can define treatment principles for Meibomian gland dysfunction, which include, of course, the increased lubrification of the eye, then the reduction of the tear evaporation. If you have this infections, which are frequently associated with Meibomian gland dysfunction, the infections and inflammations of the tear margin, then you should give anti-inflammatory antibiotic drops or ointments, sometimes oral antibiotics. Omega-3 might help, but then there are studies which have demonstrated it does not help. What's important if you treat Meibomian gland dysfunction is the local physical therapy of the lid margin and the glands with warm compresses, manual expression of the Meibomian glands. You will be surprised how the meibome changes depending on the grade of Meibomian gland dysfunction. These principles have been taken up by LipiFlow. This is a device from the States, which is a high sophisticated device. Has its advantages, but the disadvantages from my point of view are first of all the pricing, and then that the automatic expression of the Meibomian glands sometimes is not sufficient enough. Lid scrubs for the lid margin are important. These are Blepharoplasty type treatments, and especially when you have a Demodex infection, this improves the situation a lot. And then recently there was a treatment introduced, the IPL treatment of the lower lid, and they claim that the positive effect on the dry eye is via the treatment in this area where the Meibomian glands are in the lower lid. So applying all these principles which I just showed you, I combined this with the Tixel treatment, learning or having learned from the effect with the aesthetic treatment, Tixel treatments, PeriOrbital. And I tried to define what I called the Andorra dry eye formula with different steps. So the first steps is I called clean lid, which is the combination of the principles which I showed you before, the heat exposition and the lid scrub and the manual expression. And this is then followed by the Tixel PeriOrbital treatment, which I repeat 2 or 3 times every 2 weeks, sometimes again with a repetition of the gland expression. And when I don't see any obstruction or any inflammation of the lid margins, then I start right away with the Tixel treatment. The Tixel treatment consists in 5 shots in the lower and in the upper lid next to the lid margin. The parameters, and Sunil will talk about this later, 8 milliseconds and 400 protrusion, and do 5 more shots a little bit higher and a little bit lower. And oh, this is, but you can see it. It's torn, but you can see that the treatments on the lid margins are very, sorry for this, but we can't change this now. You can see that the treatment technically is very, very similar or basically the same as the aesthetic treatment. The only difference is that you don't go as high in the upper lid. And treatment is very easy. It takes 2 minutes, 10 impulses on every side. We controlled and the effects of the Tixel treatment, and the results which you see here are the results only after the Tixel treatment. So without the combination of the other steps, which I explained here before in the Andorra dry eye formula, which makes the Tixel treatment even more successful. So we controlled it and monitored it with the questionnaire, the Ocular Surface Disease Index questionnaire. And you have different scores which differentiate in mild, moderate, and severe form of dry eye. And here you can see 22 patient retrospective. After the third treatment, the score lowered significantly from something like 35 to 20. And as well in this diagram, you can see how the result of the questionnaire shifted from the severe form of dry eye to a mild or the normal form of dry eye. The second parameter which we used monitoring the effect of the Tixel treatment was the non-breakup time. And as an example for the non-ophthalmologist, what you see here on the left side, everything what is red here is the instability of the tear film, mainly due to the a lipid layer which is not sufficient. And after Tixel treatments, you get something like this, where everything is green, which means that you have a stable tear film. And looking at the numbers of the seconds, which is the parameter actually of the non-touch breakup time, we could find an increase after the third Tixel treatment from 8 to 12 in both eyes. And this is a remarkable improvement of the treatment. Then we started with the prospective study, and this part is from Professor Sunil Shah. Sunil, maybe you can take over right now.
So Ludger done this amazing work where he sort of documented his initial findings when largely treating the cosmetic patients. But what we didn't know at that time was that just the magic in Ludger's hands, or was this something that we could reproduce in different sites? So we started a clinical study with 3 sites, one in Birmingham, one in Andorra, and one in Cambodia. So slightly different populations, slightly different territories. It's, obviously Andorra is at some altitude. Cambodia we included for Asian eyes, and my particular group of patients are a little bit more complex. We laugh as a corneal surgeon. The main thing we do with dry eyes is create it rather than treat it, because we're doing so much surgery. So lots of my patients were actually surgical patients. So as Ludger said, we have new definitions for dry eye, and in particular we're talking about instability, hyperosmolarity, and inflammation. I mean, inflammation is a relatively new concept within dry eye, but we have a huge population. So for those of you who are not ophthalmologists, to be thinking that 50% of your patients may have this problem. So the market is unbelievable. And as you've seen from what Ludger said, there's not one treatment which will do everything. We have to do a number of different things to treat these patients. But the difference with this study was we removed all the additional interventions and only did Tixel. So the study was just to see what Tixel treatment to the eyelids did to the signs and symptoms. And that that with dry eye, it's notoriously difficult to get objective measurements which actually prove what you do. So a lot of the sort of lubricating drop studies, they only go for equivalence because they can't actually prove that their drop is any better than sort of the contender. But we were trying to see whether we could find something which was objective. What we did was an initial assessment, and the first treatment, as you saw, which was 10 shots on each eyelid, 2 rows of 5, as close to the lashes as you could for the first row, and just slightly overlapping. And then we'd see them again 2 weeks later, assess and do a second treatment, and then see again 2 weeks later, assess and do a third treatment. And then they would have subsequent follow-ups just to see how they were getting on. So what we did for inclusion criteria was we had a questionnaire, which is the OSDI questionnaire, and they had to have a score of greater than 13. And you saw the pictures that Ludger had about non-invasive tear breakup time. So this is looking at tears and getting a machine to tell you when there's been a certain amount of tear breakup. We've gone for a non-invasive method because the traditional invasive method, which is we put fluorescein drops into the eye and then count how many seconds on a slit lamp before the tear breakup time was seen. That's notoriously unreliable because it varies from person to person. It depends on how much fluorescein you put in, all sorts of other factors. So to try and do an objective measure, we went for the non-invasive version. So the dry eye symptoms we assessed by a speed questionnaire and an OSDI questionnaire. TFOS used 2 asks you to look at osmolarity now, so for the tears. So looking at effectively concentration of the tears. Obviously, non-invasive tear breakup time, as we discussed. We also did topography keratometry. I'm not going to present that data, but there's a lot of evidence to show that when you have dry eye, if you do biometry measurements with the patient on dry eye, then the results are poor purely because of the dry eye. So we're assessing that as well. And obviously there's a full examination, and we were assessing the lid and the Meibomian gland. We were not expressing the glands for the purposes of this study. So to date, this is an ongoing study. Obviously, COVID has played a role in slowing down recruitment, but we have 72 participants between sites. Average age of about 56. As you'd expect, majority are female. In terms of complications, no complications other than mild erythema of the skin, which disappeared within 2 days. So the OSDI questionnaire. So this is a short questionnaire to try where you have questions designed to try and tell you whether you have dry eye. So this is scored, and the scoring works as sort of 0 to 12, which is down here, is a normal result. 12 to 22 is mild, 23 to 32 is moderate, and over 33 is severe. And if you actually look at our patients, at baseline, the average was 47. So they're all testing, the mean is that they're quite severe. And following the first treatment, so 2 weeks later, you saw that drop down to 34. Not much difference after the second treatment. And after the third treatment, we're down at 25. You can't see this side completely, but if you so this color here, the maroon type color, is the severe patients. You can see that originally there were about 30% were severe, and that dropped down to 20% after the treatments. The same with the moderate and the mild. You can't really see the normal, but there's a reasonable group of normal patients after this. So we also did a speed questionnaire because all of these questionnaires vary somewhat. And with the baseline on that was 14.7. This showed an improvement at every visit. And if you look at the, perhaps look at the patients who were testing normal on speed originally, and look at how big that group is at the end of the treatment. So so we're talking about 75% of the patients were testing normal on speed at the end of 3 treatments. So non-invasive tear breakup time had a modest improvement. So at a baseline, this is the right eye and left eye over here, 7.2 up to 8.8 as a mean. But in this, if you look at the subdivisions, there were about 56% who improved by greater than 2 seconds, and 41% who improved by greater than 3 seconds. Now, may not sound a lot, but actually, for something like this, that is a lot. Now, if you look at osmolarity as tested by the Tiel lab, we went from sort of 298 down to 291. So that's a reduction. So in osmolarity, we're looking for a reduction in over 7 milliosmoles per liter. With Tiel lab, what is said to be a minimum clinically significant reduction is 5. So if you look at comparison with other devices which are out there, so the obvious one is intense pulse light, and you can see that you can't do direct comparisons for everything because everybody does their studies differently. But our results were 14.7. Original speed score went down to 8.6, and you can see that most of the studies started at similar levels. A couple of them were slightly better. Another one was about the same. But I mean, what was interesting with this is that I mean, I have 2 different IPL devices, and I have a Tixel device. With the IPL, I just don't get the wow factor. You know, you don't get patients coming in very happy that something's happened following a treatment. But you know, this is a comment from one of my patients, and this was actually just her first treatment. And we're thinking first treatment, you're not going to get much impact. But I don't think it was placebo because she had improvement in all of her objective signs as well. But she was a very happy patient. And this was one of my post-operative cataract patients who couldn't see very well with a multifocal lens because she just had too much dry eye. We will take questions at the end. We're almost at the end, so just bear with us. So the most recent study of looking at IPL was by Jennifer Craig in New Zealand, and we just tried to show our results compared to hers. So we've got 72. They had a mixed group of 57. They did 4 treatments. We've only done 3 so far. But if you look at the changes in our tests, so with the OSDI, we had a drop or an improvement of 22. They only had 7. With speed, we had 6.1, they had 4. With non-invasive tear breakup, we got 1.5, which is modest, but they only had 0.4. And osmolarity, theirs was not significant. So if you remember, that was 2, 5 is the clinically significant measure. This was only 2, whereas ours was 7. So in conclusion here, we've shown that Tixel improved dry eye questionnaire scores. So OSDI score improved more than 22 and speed more than 6. With OSDI, which is probably the biggest validated one, with figures telling you what is a minimum clinically important difference. They feel 4.5 improvement for moderate dry eye and 13.4 for severe dry eye are the important numbers. And we were getting greater than 22. We had non-invasive tear breakup, which improved by greater than 3 seconds in 41% of patients. And our osmolarity improved by more than 7, and the minimum clinically significant reduction is 5. Why does this work? We assume this is Meibomian gland impact, but there's an awful lot more work to be done on that. So I'm just briefly going to go through some of the features of the device if you're not familiar with it, and then we'll take questions. So firstly, we're talking about direct heat transfer from the lid, from the device. And there are no secondary effects. And the things that you can change with the device are the pulse duration and how far there's protrusion of the tip. The device itself is very simple. You have you choose your exposure time in milliseconds, and you have a protrusion in micrometers. So for this study, we were fixed at 8 milliseconds and 400 micrometers protrusion. These are your number of spots left in your hand set. Remember, we only use 40 for each treatment for dry eyes. And as you can see there, 400, that's the temperature of the tip. So this is a titanium tip, sort of stable at high temperatures, easy to clean. Obviously, 400 degrees is much higher than you'd have in an autoclave, so it's self-sterilizes, and it's just reusable. You don't need to change the tip. This does not protrude and go into the skin. This just depresses the skin. You know, we're only talking about a few hundred microns of protrusion off the head, so it's important to understand this does not puncture the skin, so this is very different from, say, cosmetic lasers like erbium or the old carbon dioxide, which actually would take off a lot of the surface of the skin to try and remove your wrinkles. And in studies, the average depth of effect within the skin is about 200 microns, but it's very localized effect. As you can see here, no bleeding, no carbonization. It's not no pain, but there's low pain. So most of the patients, certainly in Andorra, more than in Birmingham and Cambodia, have had no anesthetic. But you can apply a lignocaine gel to reduce this if you need to. There's absolutely no downtime, and it's, as you've seen, it's very quick. And you can see that, so histology of this treatment, there's your lesion at 0 days. Even at 1 day, this is improving, and after 8 days, there's nothing to see. No break of the actual epidermis. and no crusting. So what about the amount of energy compared to IPL? I mean, obviously they're different. I mean, one's light and one's heat. But if you use a mathematical model for this, the amount of energy that Tixel uses is 1,000th of that with IPL. So there are a lot of unknowns with IPL. I mean, you know, there's a huge amount of light going on. So the operator needs to either close his eyes or be wearing some sort of shielding. We really don't know what happened because the patient, even through closed lids, can see this light. So you worry about this amount of energy getting through to your lens and to the retina. What about how far this temperature goes? So even though at the tip you're at 400 degrees, within 100 microns of depth, this has only gone down to 50 degrees centigrade. So it's a very rapid drop. So one of the things we've been talking about is this is not a direct thermal effect on your Meibomian glands. It can't be because the temperature is a gradient drops off too steeply to actually get to your Meibomian glands when you're doing a treatment on the outside. And you know, you see discrete lesions on the skin. There's no carbonization, there's no bleeding, and also importantly, just you know, with that intense pulse light, you have to be careful. You have to be very careful in dark skins, whereas this works on any skin without any type of skin without any problem. Okay, thank you. So happy to take any questions.
Maybe there is a first question. What about the maintenance post-Tixel dry eyes? As Sunil mentioned, if necessary, we will allow them to take some lubricating drops. But many of the patients, even after the first treatment, don't need drops anymore, at least not as frequently as they have done before. And if there are serious infections of the lid margin, I do the treatment anti-inflammatory or with antibiotic ointments before I start with the Tixel.
Erez, can you just take off the screen share?
Well, should I just continue with another question? So the question is, treatment every 2 weeks, whereas for the face, it's every 4 weeks. Does it possess in danger since we need around 4 weeks for current results to be produced? What the ideal parameter? The patient gets a course of 3 treatment. How long will it? Okay. Our intention for the dry eye treatment is different than from the aesthetic treatment. When I do aesthetic treatments with the Tixel, I wait as well 4 weeks. But we apply only 10 shots on each lid. So in order to get an intensive effect, I, for default, choose and try 2 weeks. Whether 4 weeks would be an alternative better or worse, I can't tell you, but my experience is that if you do the first treatment, then in many patients you have a direct effect, but this effect loses a little bit of intensity after a couple of days. The direct effect, for example, patients tell you who normally use contact lenses that on the first, second day after the treatment, their contact lenses started to get dirty, that they have meibom secretion on their contact lenses, which for me is a proof of concept. But this mellows down this effect. So waiting 4 weeks, I thought after the first observations is too long. So I prefer 2 weeks. So 2 weeks, 3 times. And then I found out that the effect is quite reliable. And I've seen many patients which didn't need any more for up to 12 months.
I think it's a very interesting effect. I mean, it's a lot of the patients say 2 or 3 days later the vision goes blurred, even if they haven't got contact lenses. And you obviously can't say exactly what it is, but it makes sense that this is release of meibomian secretions, because it disappears within a day or two. And certainly with ours, I think I've found that that's probably more noticeable on the first one. I've not had so much comment, whether they're used to it, but they don't comment so much on subsequent treatments.
Yeah, I can confirm that in Sunil you had this wonderful picture taken of a patient who developed something, yeah, comparable to a sty after the first treatment. And there was an accumulation of meibome stuck in the Meibomian gland, in the exit of the gland, and then it opens and got away. This is kind of a proof of concept as well, that we do something with the Meibomian glands. How many shots per eyelid? 10 per eyelid. 1 row with 5 shots, and directly next to the lashes, and then 5 more shots a little bit lower and higher. Then settings 8-400 normally, but you can go down to 6-400, which is a little bit less, well, I wouldn't say painful, but if patients are a little bit more sensible, they can complain a little bit about the impulse, but it's an instant, yeah, how would you call that, Sunil? The effect, it's not pain, it's
discomfort. It's
discomfort, yeah, that's a nice description.
So just so certainly for the purposes of this study, we've not repeated the treatment as yet, but Lucas, I think you've had some who've repeated after a year or so.
Yes, it's many don't come before 12 months, and then if you repeat it, you don't see them again. And in my area, patients come back because there aren't that many alternatives nearby. So I think I have a pretty good follow-up to the patients which I've treated, because most of them, 90%, come back for the second and third treatment. And then we send them and try to get as much information with the questionnaires afterwards. But as you all know, if patients are happy, they don't have very high intentions to fill out these questionnaires. So we have to get more figures and numbers for the follow-up after 6 and 9 months, for example.
So I think some of the questions on the chat, we've got the topography keratometry data, but we haven't looked at it yet. Because unfortunately with the virus, some of the information was on the equipment, not easy to analyze. There's a question which probably Lucas should do about blepharoplasty. I've not used this cosmetically, so who are the ideal candidates for blepharoplasty?
The ideal candidates for blepharoplastic are the candidates that don't want surgery, which don't have a very developed blepharoplastics, that they don't have any kind of contraindications. And as a non-invasive blepharoplasty, if you repeat it 3, 4, 5 times, you can get excellent results that they don't need surgery anymore. If you have a very, very developed blepharoplasty, then it's not sufficient. Then you have to do surgery.
So Rand's asking about the exposure time is fixed on the machine, so you can see the device here. So so if you go for 8 milliseconds and 400 microns, that's all you get. You can't overexpose unless you fire again. So then that would be sort of operator dependent, not device dependent.
There is an interesting question. For ordinary practitioners, is using the Schirmer test good enough objective follow-up? I don't think I don't like the Schirmer test at all.
But, yes, Susan, maybe you should look at the fact that we've not even used the Schirmer's test in our study.
Yeah,
it's
not reliable.
Both of us feel it's there's just so many variables in it that it's not good enough. There's a lot of evidence to say you can just use a questionnaire. You know, if you've not got the ability to examine the eyes properly, the questionnaire will give you a similar sort of data. I mean, we both feel this is a very safe treatment, so we're not too worried on that front.
Well, then there is one here.
I think we don't have an answer to that. The last question as to percentage loss of meibomian glands. I mean, this we're presenting the first prospective data, so we haven't got vast experience. I mean, although Luke has got a number of years of experience of this, we haven't been looking at everything. So these sorts of questions we'll be able to answer over the next few months as we analyze the data a little bit more.
Yeah, we will look at the meibomian glands. The problem with the parameters is that there are so many, and we don't have the parameter which will tell us dry eye has improved X%. So we try to put as much together what is kind of possible without an extensive workload. And the subjective parameter for me is a very, very important parameter, although of course it's always a week if you started a discussion among professionals. But if the subjective questionnaires gives you a good result, this is actually what we want as physicians. We want happy patients, and if they're happy, then we're happy as well. But of course, we have to look at possible objective parameters as well.
But there's a question on cost. I can't help you with that. I mean, I think you need to talk to your local distributor on that. My impression is that it's very much cheaper than intense pulse light, both from the cost of the device and the ongoing costs, because intense pulse light can be quite expensive. Ludko, what parameters do you use for surgical blepharoplasty? What settings on the system?
Well, not for surgical, for the non-invasive.
Sorry, no, for not surgical. It's Tixel blepharoplasty.
Well, I normally start with 8,400 and then wait on the reaction of the patients. And if I do the non-invasive blepharoplastic, I normally use some numbing cream, and if the skin tolerates well the Tixel impulses, then with the numbing cream, I'm going higher up to 10,800 as well. Without numbing cream, 10,800 would be a little bit too painful in my experience. But if patients tolerate, or if the skin tolerates well, then I go as high as I just mentioned.
Okay, so there's a few more questions. Yes, if you've not got equipment, yes, assess tear breakup with fluorescein. I mean, you can do what you do normally. I mean, this was for the purposes of a study. We needed to try and get objective measurements. After treatment, it's up to the patient. I mean, you will find that they will automatically reduce the amount of drops that they are using. So, even if they keep up the same frequency and they're more comfortable, that's still a success.
We have to differentiate a little bit between the mild, moderate, and severe dry eyes. For example, nowadays, and in COVID times even more, people are sitting in front of a computer, as we all do with our Zoom webinars, hours and hours, and they all, the guys, the IT guys, they all have a bottle of lubricating drops next to their computer. If you do the Tixel treatment, then most of them are completely free of lubricants, and they don't consider their problems. I mean, the IT guys, for example, I talked to many of them. They don't consider their problems as dry eye problems because they don't know. And what you can do, you can educate these kind of patients, which I always would consider as moderate dry eye, or mild and moderate dry eye, but you can educate them how to do their blinking in front of a computer. And if you combine this with a Tixel treatment, which is it's so safe and not invasive at all, fast, and no dramatic side effects, then this is a very neat treatment, which they really appreciate.
So I think the question about LipiFlow, I've answered it. We haven't done that yet. That will come.
But let me answer this.
Okay.
If you do the Tixel treatment and combine it with the other steps, which I showed in this Andorra dry eye formula, so applying the principles of LipiFlow, which are completely right, so heat and expression of Meibomian glands, if you combine that in a manual way, and maybe as well the lid scrub with the Blepharoplasty type technology, then this is one step which is completely different from the Tixel. In my experience, the best way is to combine these steps with a Tixel, and then the results are even better. We will look for that, and we will demonstrate this in future studies, because we wanted to demonstrate right now the effect of only Tixel treatment. But in my clinical experience, the combination with the other steps is even a lot more successful.
Still lots of questions coming. So I think that the MGD and acne, there's no difference. I mean, if you look at the dermatology side of Tixel, this is being used as a treatment for acne in any case. So I don't think you have to change anything, and your acne is not going to be right up to the lid margins, as in you are trying to do 2 rows of treatment just on the immediate lid, so a little bit further away. And I don't think if you're going to treat the acne other than tetracycline, I wouldn't. I think you'll have to ask about Roaccutane and things. I'm not familiar myself on that side, whether you can use Tixel in with other treatments. And Marie's asked about when would you use IPL and when would you use Tixel. We will find out with time, I think. My thinking is that I will start using IPL and restrict it more to patients who got active rosacea or ocular rosacea or vascularization on the lids, more than just a more straightforward dry eye. But that's yet to be seen, and we haven't done enough patients to be able to subdivide the groups up to analyze that in data.
But both of us, Sunil and myself, we have an IPL and we have Tixel. So doing a direct comparison is a very interesting objective. We haven't done that, but looking retrospectively at the different effects or intensity of the effects, then in my experience, the wow effect, which Sunil mentioned before, I haven't seen with the IPL. I have seen it frequently with the Tixel, and we will in the future compare it more extensively.
I think I mean, from a commercial viewpoint, as ophthalmologists, both of us as refractive surgeons would say, well, why do you do LASIK rather than PRK? And one of the things is the wow factor, which gets your patients to tell all the other patients, and their own form of advertising. What do you feel about that, Ludger? I mean,
it's a pretty good and neat comparison. There is another thing which, yeah, it's not that it worries me, but I always have it in my mind that the energy of IPL, which you apply very close to the eye, and I saw this question in the chat about the Tixel technology. The energy of Tixel is so low, and I've never seen any complications, even though we do the treatment close to the eye. We don't do it on the eye, we do it to the lids. But the energy can't, at this energy level, in no means pass into the eye. In IPL, I don't want to say that it passes into the eye, and I've never seen a complication, but sometimes these things, especially if you apply energy on a high level, close to the eye, close to the macula, hopefully we will never see something. But this is what I have in my mind as well. Then there was, is there a need for gland expression post-treatment? Well, you develop a certain vision for Meibomian glands if you see so many, and how they look like on the lid margin. If I'm not going to do a study demonstrating the only Tixel effect, I nearly always do a gland expression in the beginning of treatments. And if I see that there still is some blockage, I do it in between the different treatments with the Tixel as well. And I feel this has even better effect on the results.
Well, I think, that one of the take-home messages is that we haven't got a perfect treatment for anything, but there are a lot of different things that you should be doing to optimize the patient's tear film. The data we've shown is purely on Tixel, because we thought if we start doing multiple interventions, we're not going to be able to analyze what Tixel is doing on its own. So the likelihood is that real life data where you have optimized their Meibomian glands, done the expression. If they are inflamed, you might have given them a course of steroids. There are a number of other things that you might do. And obviously, if they got blepharitis, then you might actually need to Blephex or something like that. This is a tool which will treat part of the problem, but from what we've seen, it seems to be treating that part of the problem extremely well. And far better than any of the other things that we've used so far. I mean, both of us are experienced ophthalmologists with an interest in dry eye. You know, as I was joking earlier, both of us create a lot of dry eye because we're primarily surgeons, so we have to know how to treat it. So we've been involved so much because we feel this is a game changer.
And it's so important as a refractive surgeon, if you implant multifocal lens or post LASIK, and you can offer them something which helps the patient. And this is, again, goes into the direction of questionnaires. You need a very good tear film if you do implantation of multifocal lenses. Otherwise, the quality of vision is deteriorated. And patients are not happy. And you're not happy if a patient can't see well after implantation of a multifocal lens. So if you can solve this problem with a Tixel treatment, then you know that there is a very positive effect, which is very valuable for us. There is another question: do you change setting for darker skins? No, I think this is one of the one more advantage of the Tixel. You don't have to adapt the settings to the skin color. With IPL, of course, the situation is different. And I apply sessions during summer as well, but this is the next question. But of course, I recommend sun protection. But on the other hand, in summer, most of patients wear sunglasses now. So if you treat only the skin or the periorbital regions, or these 10 impulses next to the lid margin, this area normally is quite well protected with sunglasses as well.
So I think probably just finishing off, as we're over an hour, but yes, this talk will be on YouTube. The feeling about doing Tixel before eye surgery is an interesting one, because I have been doing IPL on about a third of my surgical patients before surgery. So now I think the likelihood is we'll be switching over to this.
I do it if the OSTI, every refractive patient in my clinic gets an OSTI, the questionnaires, and if I feel that they need something, and if I see any objective changes in the cornea, in the eye, in the conjunctiva, on the lid margin, I apply a Tixel. And Bill Trettler did a study that about 75% of patients which appear for cataract surgery, they actually have a symptomatic of dry eye. So I think this is a very, very important point, and you can avoid problems post-operatively.
Okay, any last questions? I think the theories we will find over time. I think we're just as interested in how this works as everybody else. We have some feeling that this is an impact on the Meibomian glands, both anecdotally and what we've seen with the glands. So how it's working on the Meibomian glands is a different question, because the heat does not reach the gland, so there's some other action. We've got a study planned as soon as the virus is over, where we'll be looking at constituents of tear film to see whether we can identify what's going on. But as I said, this is the first prospective study on this device for dry eye, and we have a lot to learn going forward.
Yeah, we can't answer all questions 100%, because as Sunil just said, we have to continue with learning and getting experience, and maybe we even change and modify a little bit the parameters in the future and do things different. But this is how it is. If you start examining an effect of such an interesting and new technology.
Okay, so I think I'll call the meeting to a close. If there are any burning questions, you can always contact us sort of directly for with questions. But thank you all for attending, and I think from the comments we're getting, everyone's enjoyed this. Thank you.
Thank you very much from my side, and enjoy the rest of the Sunday. Bye-bye.
Bye-bye.